The next session is going to be about training the trainers program. This is a flagship program of ARC, which is aimed at inculcating and rather involving the teachers in various parts of our country and trying to motivate them and to teach them the learning techniques of it. So today's session, can I request Dr. Chairperson Dr. Ravindran sir and Dikyan sir is here to come. We had 30 participants who have registered for this particular program, but I think it's a lunch time also, people will be joining us. Okay? So, we have moderator Dr. Deepak Mishra and Anaga Herur. Anaga has gone for surgery. Can you just call Parikshit? Deepak Mishra. So moderator will be Dr. And the panelist is Dr. Professor Manisha Nadar, Dr. Abdul Waris, Dr. Jatinder Singh Balla, Dr. Suchita Parijan. Ma'am, can you come on the front row, please? And Professor Vinita Gupta. President sir is on way from US and he is about to yet to reach, so we will be having the welcome address a bit later. So without much ado, can I request the first very talk by Dr. Parikshit Gogde, and can I ask Dr. Ravindran sir to set the ball in rolling.
So good afternoon. Thanks Dr. Pawan Kole and also the AIOS-ARC team for this opportunity to chair and also talk during the session. So we will start with Dr. Parikshit Gogde, a very experienced ophthalmologist, both in practice and also in teaching training, based out of Pune. To give the talk on where are we today, overview of the residency training program in India. So, yes, Dr. Parikshit.
So can you load my presentation? Dr. Ravindran sir, respected chairperson, an enthusiastic audience. Ma'am, this is some. So may I start, sir? This is a small talk on the overview of residency training in India. Well, traditionally, residency training in our country has been like the Gurukul system, in which the student serves, follows, observes, learns, and works for the Guru for 2 to 3 years, and that is how they gain knowledge. But today, teachers have to become facilitators of knowledge and wisdom. Because there have been studies from Hubli, studies from Pune, which we have done in HV Desai about 15 years ago, which showed that there is a great discrepancy in the actual number of surgeries performed by resident doctors and the perceptions of the numbers that are needed to master those. Phaco and non-cataract surgery teaching was neglected, and the residents wanted to be evaluated regularly, taught basic examination, use of equipment and procedures in grade 10. With this in mind, in 2014, the ARC, the Academic and Research Committee of AIOS, had started the READ study under Dr. Partha Biswas's leadership. This was to get a feedback from young ophthalmologists who had completed their training between 2004 to 12, who were 21st century trained, who were young enough to remember their training, but now experienced enough to understand what was the lacuna in that. Because when we ask residents, all the residents say, we want to have more surgery. But those who have gone out, been in the world for 10 years, when we ask them, what do you think was the lacuna? And we compared them with people who were 20th century trained between 1970 to 2000, to help AIOS frame guidelines for residency training. Well, now there is a huge difference in how India was 40 years ago and how India is today. Today we have 400 million children. Cataract is still a common cause of blindness, but earlier it was 80%, now it's just 50%. And the retinal diseases, glaucoma, they are becoming more important as corneal infections have reduced. So I will not go into the details, and the respondents, they were from all states, but if you will see, one of the difference that we see over here is, in the 21st century, there are more women who are there, who are being trained. Again, those who are second generation doctors or who are from a family of ophthalmologists have also increased. So that way it's becoming more familiar. And even today, almost 1/3 of residents took ophthalmology as their first choice or as a top choice for their career. So they are coming into this stream very willingly. Again, that way ophthalmology as a career is lucrative, there are no emergency hours, you can devote time to family and hobbies. But still, there is a huge entry load for private practice. It's competitive and perhaps not that lucrative with NGO hospitals and charity. So when we looked at the rating of clinical skills that was taught during residency training, we found that refraction, the median is just 5.2. It's less than what it was for people who were trained 2 generations ago. For the rest of it, generally there is an improvement because of course everybody now has a slit lamp, a pachymeter, a A-scan, B-scan, keratometry, arc laser. They are now not, something that is new in residency. When we look at skills for glaucoma diagnosis and management, again there is a huge improvement because earlier there were hardly any applanation tonometers. Today, again gonioscopy, applanation, pachymetry is there. But if you will look at again the median part of it, how they want to learn, things for OCT or gonioscopy, it is still not the perfect 9 or 10 that they would want. And one thing which showed is, in the earlier cohort, people would do about 5 trabeculectomies before they pass out. Today, the average resident does, on a median, only 0 trabeculectomies. There is hardly any glaucoma surgery that is being taught in our residency training at this point of time. It has all gone into fellowship. So even we say glaucoma is the second leading cause of blindness, yet we have a case control study from Pune which has shown that even if a patient visited a doctor, an eye doctor, in the last 2 to 3 years, their glaucoma was missed. So a visit to an eye doctor was not protective for late detection of glaucoma. So glaucoma today even is a disease which is underdiagnosed but over-treated, and young ophthalmologists need to be made more confident in the training and the management of glaucoma. Similarly for retina related skills, so we have our ARC chairman who is a very enthusiastic retinal surgeon. So again here, most of the retina related skills have become better in the last 20 years. Indirect ophthalmoscopy, 90D evaluation, OCTs, fundus photography, there was hardly any OCT before 2000, but fluorescein angiography. So it is much better when we are comparing it with the older cohort. But if we will look at in the developed countries in Europe or the US or Israel, there an OCT is a norm. It's like we do a direct ophthalmoscopy over here. That is still not happening in our residency training because still many medical colleges do not have this equipment. So there is a wide variation in the programs regarding retinal training. Most programs offer vitreous or retina surgeries only to fellows, not to their residents. And we know retinal diseases are a leading growing cause of visual impairment. The pre-millennium residents were never taught OCT or retinal lasers, but even for the post-millennial residents, it is still inadequate. And people would want to do a proper fellowship if they want to specialize retina. Comprehensive ophthalmologists as such are not being exposed to it. And I'm a pediatric ophthalmologist myself. When we look at skills for the children's eye care, and there are about 400 million children in India, that's almost 1/3 of our population. Again, perhaps in the 20th century, the median was much better as far as synoptophore, diplopia charting was concerned. And even then, strabismus surgery was not performed that much. Even today, in the residency training, hardly there are very few places where strabismus surgery is taught to the residents. It is something that they have to do after they pass out and they do a special fellowship. So again, for those 500 million children in India, there are just 500 odd pediatric ophthalmologists. And visual acuity assessments, amblyopia treatment, orthoptic evaluation is something all ophthalmologists must know if we are to address this problem. And again, for the deaf mute, the learning disabled, the autistic, the physically challenged, there is hardly anything. And finally, if we look at the surgeries performed independently during residency training, then yes, in the last century, the most common surgery was intracapsular cataract extraction. Today now, it has become manual small incision cataract surgery, followed by phacoemulsification. Again here, the mean is quite big because there is a huge variation. If we look at the median, then 50% of the residency training programs in India give one or less phacoemulsification during the training program. So the variation is huge, and if you will see, other than pterygium and chalazion, all the other surgeries, the median is almost zero for even things like DCR, retinal detachment, vitrectomy, keratoplasties. This is something that a resident is not being exposed to during their residency. We also ask them about their taught academic program. So here again, they like a lot for wet labs, but which were not much. Now this has changed thanks to AIOS. There is now SSTC, TSTC, DSTC, and in the last 7 or 8 years, there has been a huge change, and we are moving towards wet lab and simulation. The AIOS headquarters now has a cataract surgery simulator. So yes, a lot of new things have happened after this study has taken place. Again, if we look at the dissertations that these students were given, one good thing is that a lot of the dissertations have been presented at local and state level, but that's still just 1/3 of it. And a lot of them have been presented by the students themselves, not the teachers. But again, if we look at the national and the international level, it's still very, very less, just about 7% or so. And I think that too also from residents who have been taught in say AIMS or LVP or PGI, only because they are only getting to do that kind of research, or Arvind. And in the rest of them, well, there is not much to show about. So the strengths of Indian ophthalmology is still a sought after career. There are more second generation doctors choosing ophthalmology. Almost all clinical skills, teaching and exposure to investigation has improved over the past decade. Exposure to cataract surgery is adequate but not uniform. And manual small incision cataract surgery is still the commonest surgery that is taught today. There are many more women in ophthalmology that we just have to walk out and see. But the weakness is there is a geographic imbalance. Just 5 states of India, and they are all southern states, Maharashtra, Karnataka, Tamil Nadu, Andhra with UP and Delhi, have half of India's ophthalmologists. Journal clubs and wet labs were being underutilized. This is changed now. Simulators are there. But non-cataract surgery is still not being adequately taught. Midterm assessments are rare. And exit exams are mainly theoretical and practical exams inadequate. There have been residents who have not done a single surgery, but they are still master of surgery at the end of their term, and they have a certificate to show that. In some countries, we have pre-entry assessments like binocular visual acuity assessment before you are going into a surgical line. That is still a long way ahead. Yes, we have institutes of excellence. There is Arvind, there is LV, there is AIMS, there is SN. But again, in many ways, they are an oasis, and it's not an evergreen forest. And AIOS is doing its own bit to change that by having young ophthalmologists being taught more and more skills. And I think we still need to do a lot of that more. So this huge variation that is there in teaching, clinical, surgical and academic, all of them, well, this has to be standardized. We need a structured residency program. Today, it's all cataract focused. Cataract is important. A lot of us earn our bread and butter and perhaps jam by doing that. But then there is still more to ophthalmology than that. And we should focus not on what is taught, but what the student learns. Just one last one. All this was the student's perspective. There is also a teacher's perspective that we have taken. And again, in this teacher's perspective, teachers agreed that we need to improve the clinical skills much more. And again, surgeries need to be performed more, but they are not able to do that because they have too many residents, and there is also an emphasis on quality. So last I would like to conclude is, when we are having new residents, when we want new ophthalmologists, it's not just their heads or their hands, but also their heart. They have to be compassionate. And well, AIOS is doing a lot for improving residency training, but we still need to do a lot more. Thank you. Thank you for giving me this.
Thank you, Dr. Motke, for the wonderful presentation, and we all know the results of this, and will, as you already told, the AIOS is already trying its level best to increase the residency training, and I think your few of the answers are our future guideline we will get in the next talk by Professor G.S. Tetiyal sir. He is the Chief RP Center AIMS New Delhi and the Vice President All India Ophthalmic Society. Sir is going to give us some ideas how we can have a structured curriculum or increase that in there. I request ma'am to please join. Sir, ma'am, please join. Sir.
Good afternoon, chairpersons and dear colleagues sitting here. I think teachers are not only teachers, the students are better teachers because they are the future. And I just listened half of talk from very I think one of the best teacher I've seen for society-wise. It talks about all the basic aspects. But is there a possibility for us to modify, enhance the curriculum which is there in our country? And that is what I like to stress my point on some of the areas or these areas. And then these are basic postgraduate courses which are there in the country. So basically, it will be AIOS-MT, which is a 3 years duration course in our institutions. Or you have a diploma, which is DAT now. And DO is 2 years, it's a shorter course. I think that requires a further enhancement by doing some other supplementary courses also. So basically we have MD, MS and DNP, which are major areas of concern. And as institution-wise, we have a government institutions, which may be a medical institutions, universities, state governments have their own universities and medical colleges. Then we have a huge, major area of sources for teaching is private university medical colleges. If you look into autonomous bodies which are not under the NMC, they have a different output in terms of giving a good teaching to their students, because they normally would look into NMC guidelines also. Also, they'll put their own ways to enhance the teaching for postgraduates, depending on our institution's requirement and placement also. And normally these are having a larger patient volume, because patients are one of the best teachers for us. But unless we have a patient clinically, surgically, then how can we impart the teaching for our students? I think that is one area we have to look into. And other area which is important in these institutions are, they have their own ways to institute teaching curriculum, own ways to look into the research aspect of these students. And these institutions have done well. So they are basically an institution of national importance. And second important area which has a larger medical universities and colleges are state areas. Unfortunately, most of them have not gone into a proper enhanced ophthalmic institutions, because most medical colleges will have a department. And today, department is not a sufficient area for imparting the future way of taking care of ophthalmic teaching and training in these areas. So we need to have more enhanced departments which goes into upgraded departments, or they become RIOs. And there's a restriction of RIOs, you can't have many RIOs in the various states. So maybe you can have upgraded department in these areas to enhance the teaching of our students. I say this because once you go through the examination process of need, the many students who qualify in the higher grades will opt for these medical colleges because financially it may be more suitable for them. But unfortunately, after 3 years, we don't make them our best possible students. They struggle to get into other areas. So we have to enhance these state areas. Private universities, they do have norms required for NMCs. They are doing very well. They have a modern facilities. In fact, some of the universities have, colleges have everything possible, which in a government setup may be very difficult to acquire them and give exposure to their students also. And there are private institutions which are only for ophthalmic institutions. They have one deficiency there. They have a very nice ophthalmic setup, but may not have the other departments attached to them. That is like presumed neurosurgery, neurology, cardiology, which also should be integral part of our teaching of our medical students. That will be a postgraduates also. So these are basic guidelines for NMC. I have put into two different objectives here. Basically, as we said, like there has to be uniformity in a PG teaching curriculum across the country. Let it be government setup or a autonomous body or a universities, private. They should have a proper uniform standard PG courses. We should focus on a enhanced curriculum, training, assessment and research part. And these are four important aspects which will be covered in a very modular training structure, which is a structured modular program, and should look into a clinical aspect, theoretical research, and effectively have elective postings also to different sub-specialty of ophthalmology. So these are 4 or 5 areas of concern which is going to look into future-wise, and these are areas where training is done. You see clinical is major area, surgical, wet lab training, research component, and these are 2 important mandatory parts for students which normally the government setups are not carefully taken also. Maintaining the attendance, which is a major challenge for today's student generation, which we can't really impose for very such classes also. And second important thing which we miss in many areas of logbook maintenance. I think that is one important consideration should be given to all PG programs. The other area which we are looking for are at least minimum standards in the teaching area, or training areas. That is infrastructure. So you have to have a good OPD, OT and lab services, which is focused into our equipment, which are up to date, recent, and they're applicable to a current day practice for a patient care and research. Apart from that, patient load is very important. And the most important part in the teaching area is faculty. You need to have enough faculty as per the ratio. Our student versus faculty ratio should be there. And you should have right from the HOD to a professor, additional or assistant professor should be adequate in these cases. And they should be well qualified and they should be up to the mark. But then the question comes here always, should we have accreditation for our teachers also? So maybe that is also an important area for a future to look into how the teachers are doing in terms of effective translation of their knowledge, their skill to their students. And the other area for NMC guideline is to have an assessment, that is the examination of these people. The one can be formative assessment, by a skill assessment in these cases, and look for other areas, which are practical examination, combined with theory, which may be AIOS-ARC and AIOS in these cases also. So these are the various challenges I thought which is there in our teaching programs. One is there's a lot of information overloaded in social media, which may be Google, which may be ChatGPT. So that is also causing a lot of stress to teachers and students, and the combination of atmosphere which is happening in classrooms. Motivation, decrease the motivation of students because we can't really give them something beyond which is available in the media. Today, if I say, okay, I'm going to take a class on how to do FACO, the student says, I can see 100 videos in those 1 hour, why should I come to your lecture? Where you're going to say something which is sort of from your side. I have views of 100 surgeons I can see there. So you have to look into that to how to get beyond that also. Classroom engagements has to change so that they come to class, and assessment challenges are also there also. So these are 6 areas which I'm going to take you through, how we're going to take. In terms of theory-wise, I think this is what we have been doing, classroom teaching for all these people, and the challenges are come, which we have to take beyond the knowledge they get to the internet. So you need to have interactive sessions. At the end of a session, you need to have a quiz or an MCQ so that we know that what they have gained after your class. Maybe you have a lot of video based or simulation during the actual theoretical classes also. And these symposium seminars should be done by students, and preceptor can be there also. So this is one area we have been focusing for last so many decades in the AIMS, where a group discussion is a major part of PG teaching. So we have first semester because we get 2 sessions every year. So we have semester systems, and we have 6 students in a 6 batches in one particular group. By maybe multiply 2 or 3 students in each group. So you have a group of 10 or 15 students, and they are the people who discuss the particular case which is being presented next day, or a journal club, or any presentation, your thesis presentation, protocol presentation. Everything is discussed beyond the normal routine class. And they are normally supervised by either the senior most resident doctor of their batch, which is labeled as a group leader, or it can be a senior resident immediate to them, or a faculty can be also labeled. Once I took over in the RP Center, I made faculty in charge for these groups so that he or she mentors these people better. It's a very effective way to disseminate the results very faster. And this can be one way of improving discussion amongst the students also. Clinical training is also is a challenge nowadays. How do we enhance the actual clinical training? I think yesterday only I was in one of the webinars where the skill has to be discussed. So I said we have an advantage, the older people, we had a very nice clinical skills by examination. Today if I say just see the fundus, they'll take the patient for a fundus camera and take a photograph. So I could do a nice fundus examination, take out all the points, draw the diagrams, and that is a skill we have. Maybe that's still advantageous. So this is one-to-one teaching to your students. You have a group teaching, and bedside teaching is still one of the important areas in the RP Center where we have the 3-tier teaching happening these cases. I think this is the one area which is being missed now, because most of the services are shifted to daycare services, and hardly any patients are there to be seen. If today a patient is admitted for surgery, we don't know what is to be done in those cases, because patient comes daycare and surgery done, patient goes out. I have no knowledge how the surgery has been done by my student. So this discussion is very, very important to generate the enthusiasm amongst the students and carry forward the training between the teachers and students. Have a very nice comprehensive discussion on a patient's care and outcome-wise also. In fact, in our days, we used to have one day, Saturday afternoon, the whole week's assessment of patient admitted and discharge and rediscussion among the group of unit also. Record keeping should be important, and as far as surgical training, nicely covered. I will not go in detail with this, but these are important areas which should be covered in surgical training also. Competency is one area which should be taken into. This is how we do it, and nowadays we don't allow a student to a live surgery of a patient. They have to really get wet lab training, certified that he or she is now competent enough to do all these steps, then only they can do surgeries. Now that to a supervised surgeries, assistants, then the individual surgeries are done in these cases. In fact, we have now wet lab simulation in a court site for any type of surgery possible, and wet lab training is an important component part of PG teaching in every institution now. And now OT teaching has also improved now. Once you have these other devices, digital devices, larger screen, that people can sit inside, the students, and see what is actually seen by surgeon in the 3D picturization by the other people also. This is, I think, briefly touched about thesis. This is one area which I like to highlight here. This financial grant is very important for our PG students. Either it is from your institute where a student is there, or from the other institution which can support that. AIOS-ARC does give award to around 50 theses. This is a 2-3 years down the line. This money has also increased now to 50,000 rupees. At AIMS, we are supporting a large number of students for a PG thesis writing and the other important investigations which are required for doing a better thesis in these cases. Today you have to do a cytokinin studies for a dry eye and require at least 10 lakh rupees for that. Otherwise you can't do it. So that type of support should be there. Every study should be having a CTI registration, and there should be a publishable thesis work so that the student gets something out of that also. This is, I think, very, very important areas to look into. Mentorship is very important for all of us. In fact, I remember my younger days, I was going through my, own days of my, MBBS days. We used to have one faculty mentor for a group. And that faculty used to take care of 4 or 5 students for all the functions. And that would give you a much more healthy, atmosphere for all of us. I think this is one important area. Accreditation, certification of institutions who are imparting these postgraduate teaching is very, very important. If not NABS accreditation for an institution, the MAC accreditation is also very, very important for all institutions to be done in these cases also. These are few important things which should be added into our teaching areas. Apart from the routine, the theoretical, other teachings, medical legal aspects should be a big aspect in the teaching curriculum, and the management part also. Because these are people who are going to become actually expert future, and then suddenly you require to do a management. So maybe some classes by MBA people or a hospital management should be a part of these cases also, and all these things should be covered. And this is what is important to enhance your area, divide your entire services into multiple specialties so that students go to each area and get enhanced training in these areas, develop research labs, have up-to-date structures which can impart not only the basic areas of research, also the surgical training, other areas should also be there. Infrastructure has to be upgraded every few years. You can't sit down in your institution that we have everything. But I know that OCT today, which was 10 years back, is not truly a good tool now. You have to have a different thing. The upgradation of these services with the rapid advances should be there in these cases. OT services also. I-banking is another area which many institutions don't think of. PG courses running areas should have I-banking as a compulsory part, and the students should also be part of the area also. I think this is the future. The emphasis on technology has to be there, advanced technology, integration of AI, telemedicine, virtual simulation will be part of our future programs of teaching also, which will take you through various areas. And one thing we are missing in India, we lack, I'm not talking about top 20 institutions. There are another 100 institutions where they don't think of a collaboration with the global institutions, because that horizon has to be changed for our students and upgrade your teaching methods as per the changing norms in a global pattern also. Allow your student to do publication from their thesis work, from their cases which they work every day, what type of symposium seminar they are doing that can be taken into a sort of a review articles and send them to our conferences, national conferences, state conferences, international conferences, and you can see that societies are helping there. If you look into our state societies, look for AIOS, we are supporting students for international travels, international fellowship programs. In future, I'm pretty sure AIOS will look into that to cover, if not 100, maybe thousands of people going across the world for various areas. To summarize the 6 important areas for future, I think comprehensive teaching have been done very, very effectively by a fellowship program for super specialty trainings, running your own enterprise in future, and that aspect will also be covered in the PG teaching courses. How are you going to survive in future, having a better professional attitude, and the 6 important areas looking to be a good clinician, be a good surgeon, be a good teacher, and be a team player. I think all these will make you a very good ophthalmologist, and future direction should be in that way where you have a comprehensive educational program, prepare them so that your students can handle the current area of patient care, teaching, research, and also looks for future directions also, because they are going to see the future and they are going to build the future also. Thank you for kind listening. And
thank you, Titial sir. It was very comprehensive and very good. I would like just to, because you are one of the senior most person in the country, sir. One suggestion I always think upon one idea I have got, that why not select institutions? They now start going for MCH retina, MCH pediatric ophthalmology, because the whole load is on 3 or 4 south institutions. And every
very
good institution can start it. Sir, the problem what we are facing as a medical college nowadays, as for example, I was discussing with sir, it's one of the oldest institute in the country. Now what is happening, sir? With AIOSMAN, catered patients are not coming to medical college. Previously we had 10 PGs, now we have 70 PGs. Teachers are saying, no cataract is coming. They are all going for AIOSMAN, private practice. So in these challenges, how to face these challenges and how to improve ourselves.
I think I didn't go into a super specialized training, but that's a different areas. And today, almost 95% of super specialized training in the private setups, like people like Arvind, LVP, Sankara, and Chitrakoot. The government setups are doing a different type of training in those areas. In recent times, in the last 5-6 years, there has been a definite focus on to start super specialty training in the government setups also, especially in the autonomous bodies and RIUs. The PGI Chandigarh is one of the first institute to start MCL. They have it cornea, refractive, retina. They are expanding in other areas also, and AIMS New Delhi is very soon going to have 8 areas of ophthalmic field where MCL program is going to come. And some of the RIOs have also started, like Bangalore, they have started refractive surgery. Calcutta, they recently applied for a MCL program. So this is going to be a feature for future also. But as far as cataract training is concerned,
So what is happening?
institutions, just to cover the last point, institution where patients are not coming, the one benefit of a peripheral reach out programs, that is doing peripheral centers, which has to be taken by the government colleges also to have a peripheral centers where your student go and attend those areas, get the patient from there. That has to be worked out because patients are not going to come to your institute now. We have to go them and get them to our institute, and that is a new mantra. Like the going to the patients is to bring them to institute is the way of future also.
Thank you, sir.
Yeah.
Thank you, sir. Now I would like to call Dr. Ravindran, sir. We will be talking about just now Ditya sir was talking about. You have to go to the patient and operate them through CAN activities probably. Welcome, sir.
Thanks again, Dr. Prashant, for this opportunity to speak in this session on training of the trainers. So I'm going to talk about how do we enhance the surgical prowess through camp activities. So it's but the term, it's not moving, slides. If you look at the meaning of the word prowess, it means ability, expertise, proficiency, but the actual meaning is exceptional skill. But for today's conversation, for this talk, I'll probably use the word competency. If you look at the need, why do we need to enhance the surgical competence? It's a need of the hour, because there are several community-based surveys have been done on blindness, which had shown that the poor surgical outcome and inadequate access is one of the major causes for reducing the blindness due to cataract surgery, especially in low resource setting. If the surgical outcome is poor, and that is also going to bring down the trust of the community on cataract surgery, it's not just going to affect only the community-based intervention, but it can probably affect the whole eye care as it is. Because we have seen whenever there has been a kind of outbreak of cluster infections in a particular state, particular area, whole state, the surgical volumes come down. So it's very important that we improve the surgical competence. It's very, very important. And again, these studies which have been done in several countries in India, Asia, and elsewhere have said that in order to address this backlog due to blindness due to backlog of cataract surgery, it's important that we train additional surgeons and also provide them with the appropriate equipment so as to address the question of access. Sometimes patients come but the equipments are not there. the trained people are not there. But they also say that if we have to really succeed, we have to monitor the quality. So having trained the surgeon, the equipment alone is not enough, but the quality is also very, very important. All this have come out of the several studies. So the volume really gives, because once you have the volume, the residents are able to operate more number of surgeries, their manual dexterity improves. That's very, very important. The volume is what it does. So people talk about, even the students talk about the volume. That is where the manual dexterity improves, which in turn improves the surgical skill, which in turn helps to bring down the surgical complications. And again, pressure, when Dr. Gogate spoke about, he was talking about the exact correct volume, which we need to have to reduce the complications. So this is, I'm just sharing this particular study we published from Aravind of 38 postgraduates, both who joined for MS and DO for 2 subsequent years, and then the next 4 years we tracked of about 13,000 surgeries. As you can see, in the first year, the first 100 surgeries, it's not working, so. Yeah, so if you see the first 100 surgeries, the intraoperative complication, which is the first bar, it's about 4.14%. The second bar is about the postoperative complication, it is 2.3%. And the resurgery is the last bar, so 1.46%. This is what we saw in the first 100 surgeries. As you can see, that number drops as the volume of surgery increases. When it goes beyond 300 surgeries, now the complication rates drops to about 1.94%. But the minute they cross about 600 surgeries, the complication rate drops to close to about 1%. So the volume plays a much, much larger role. And at least, from the study, we feel that at least a surgeon should do, resident should do about at least 300 surgeries to bring down the complication rate to less than 2%. And the number of free patients who come into the hospital and again through the camp or the outreach, which is today's talk, is really important if you want to give the volume to the residents and the fellows. But what is really important, before you have to give the volume to the residents, it is very, very important that you give them the foundation. A structured surgical training program, the first 18 months, is very, very important. Through wet lab, we heard Dr. Titial talk about it. Training by dedicated trainers, having a proper protocols, all of that becomes very important. So in our institution, at least, we start the PG's surgical training, especially the wet lab, the 5th month, for the fellows, people who join as fellowship at the 3rd month. And once we train them through the wet lab, both with the simulator, with the animal eyes, with the dry wet labs, we move them to the surgical training. They start with the manual small incision cataract surgery. The way we train them is, we train them intensely for a period of 1 month. Every day, the resident or PG or the fellow will go to the operating room with that month of surgical training. But the very first day, they just do only one step, maybe in 3 or 4 patients. Second day, they do the additional step, maybe another 3 or 4 patients. By the end of that 1 week, they are able to do all these steps. When they come to all steps, then they probably operate on only 1 patient. And as a result of this, we don't have to supervise them constantly through the next 3 years. If you are able to concentrate on mentoring them for the next 2 months, it's enough, and they become independent to operate on the 6th to 8th month. But what is important is, you must have a dedicated trainer. We have a trainer who sits with them for the whole day. The trainee also got nothing else to do other than operating and watching other surgeries, and also the mentor will also sit with them and go through all the post-operative evaluation. And again, once you have such a kind of a dedicated trainer, then monitoring assessment through logbook, all of that becomes much easier. And we have a proper rubrics for assessment, and we also have a weekly audit of all the surgeries, including all the complications. And as a part of this program, we also teach them how to manage complications, probably at the 18th month. So this prepares the person for doing a high volume. So that preparation, the foundation is very, very important. Now once we also expose them through the camp, They also have an opportunity to understand the need of the community. They also understand the challenges faced by the patient to access the eye care services. And again, when they are involved in the eye camp, they have to go to the camp and see the patients, use basic equipments like torch to identify patients for cataract surgery. Their clinical acumen also improves. They are able to understand the importance of visual criteria for selection of the patients for surgery. They are able to understand the impact of the systemic diseases. So all that helps in improving the decision-making skills. So when this is combined with rescreening base hospital, these same residents, same fellow, the patient, they have seen them in the camp. If they are able to see them in the base hospital, see them with the better equipment, they are able to coordinate with the cataract changes and the visual thing. So all this have to be a part. And again, once you want to train them in a volume, probably you have to provide them 2 tables, so they are able to operate large volumes. And again, what is important, this trainee also has to become a trainer at some point of time. The 2 years of fellowship or 3 years of residence, at least 1 month they play the role of a trainer when they become a senior postgraduate. So as a result, our fellows and the residents contribute to nearly 40% of the manual small incision cataract surgeries that are done. This I want to share here. So if you can see with the months of training and the volume of surgery, their complication rates also drops to close to around 1%. But as you see here, by 12 months it really drops, again it goes up, because until that point of time, they may not be doing complex surgeries or high-risk surgeries. When they start doing those complex high-risk surgery, again probably it goes up, but doesn't really go. If they are going to, if you look at only the normal surgery, it will be definitely much lower. But if you see the bottom, when there is the 3rd month or 4th month, the complication rates are about 6 or 7. So to conclude, exposing surgeons to high volume surgery makes them confident. They are also, when it is done through a camp, they are able to understand the importance of community outreach. They are also aware of the role played by the paramedical staff, and they are also able to develop the leadership skills, which help them in their practice later on. But the key to all the success is the adequate pre-surgical training, learning in a step pattern, close faculty supervision, and the opportunity to play the role of a trainer. They're very, very important. If they play the role of a trainer, they really learn a lot. That is really probably the foundation. First 18 months, and being a trainer is very, very important if you want to make somebody a very competent surgeon. Thank you.
Thank you, Dr. Ravindran. It was really very beautifully outlined how important structure is to a training and how structure provides discipline to surgical training, and making them trainer adds a certain sense of responsibility to them, which goes a long way. I just have one question, that there is an immense divide when it comes to different regions in the country. The amount of volume which residents or fellows get to train surgically down south is way more than what they get up north. So is there a way that we can address this issue in future? Because there is no way a resident in a North Indian medical college or even in a Premier Institute gets to do a 600 or 600 plus cataract surgery or so. So is there a way that we can come somewhere to a middle ground to address this issue? Thank you, sir.
It's all about it's all about science. It's all about commitment. I think every institution should be able to do it, because we have worked with nearly about 350 eye hospitals across the country, and we were able to do that in about 90% of the hospitals, where their volume became doubled in a period of 2 years. So I think increasing the volume is also about a science, and it's also there's a way to do it. I think it can be done.
And you told about the paramedical. I think in the whole country I haven't seen such disciplined paramedical as you are having.
Yeah.
That also adds to the efficiency of the
if you
OTs.
want to do the volume,
That we are lacking in North.
yeah, which we cannot
Only
do.
at my place.
Now, once you have the paramedical, then you can take away many of the work that is being done by the doctors and the surgeons or the postgraduate fellows, which need not be done by them. So then the role they can play also becomes much more well defined.
Ravindran sir, just a quick question before we move on to the next session. a lot of challenges are being faced now in conducting the camps. If you're aware, in Karnataka itself, now they have brought a slab where you can't operate more than these cases in these many districts under DBCS. Second thing is you need to have a complete set of team as said, led by the Supreme Court ruling that you have to have an anesthetist, you have to have a physician and all those things and show them. Third thing is all the camps should be conducted near the PHC. Fourth thing is the post-op also has to be seen there is because the people come, do and go, where should the patients go for post-op? Is the question which is being led nowadays. Fifth question is, now they are asking to do, it's called as KPME, I don't know what is in other states, where we need to have all the authority like running a hospital. Even for the vision centers, now we have to take the certification to do a door-to-door screening. So a lot of challenges now is being put forth by the government now. So how is it in Tamil Nadu? Is it the same or you have found out a way how to solve these problems without disturbing the governmental regulations?
Fortunately, in Tamil Nadu, we work very closely with the government. Government is very supportive. I mean, it's also about advocacy. I mean, in the sense, we involve the community quite a lot. So we don't do any ICAP on our own. It's always a Lions or a Rotary or a community organization who runs a camp. So if there is a problem from the government, these community organizations will go and speak for ourselves, or they'll speak for the community. So instead of putting us in the front, we put these community organizations saying that they want this to be done in their area, that all this regulation should not be there. So we also face a similar one in the districts, but
we allotted to each hospital.
no, it's not like that. So we sometimes that is put forward by the NGOs, but as a group of all the NGOs within Tamil Nadu, we all have told the district authorities and the state authorities saying that we don't want any division. We want like independence to operate in all the districts. Don't divide us based on these districts. So it's a community collaborative work. It has to be done with the community and also with the government. So if there is a problem, if one is not there, then it's not going to happen. Otherwise, it's a very challenging. Doing community work is not easy.
That's the question.
It's very challenging. Unless you have the will and to do it, you cannot be able to do it.
Exactly.
Just after one group photograph.
Yeah. Thank you, Deepak.
Sir, please.
Wait, I will also come. I also have to be there, sir.
Okay, everyone please. Wait, one more.
Thank you very much. Thank you, respected speakers and the panelists of that session.